Bom dia, pessoal. Nós vamos dar início agora ao bloco 2 do Breastmit 2024, Vigilância de Imagem Mamária após o câncer de mama, que vamos contar com a presença de palestrantes ilustres, convidados internacionais e nacionais. E para que a gente possa conhecê-los melhor, eu vou fazer uma leitura dos mini currículos. Como debatedor, a gente tem o Dr. Rodrigo Pepe, que é vice-presidente da SBM Região Centro-Oeste, que é mastologista e intervencionista na Clínica da Mama em Brasília, e é mastologista da Rede DASA em Brasília. Temos a doutora Tereza Cristina Oliveira, que é uma amiga, uma debatedora radiologista. Ela é radiologista responsável técnica pela Rede Mama, é coordenadora do curso de mamografia e procedimentos invasivos da Sociedade Brasileira de Mastologia e membro titular do Colégio Brasileiro de Radiologia. E temos também o Dr. Roberto Giordano como debatedor. Ele é médico mastologista, membro da Sociedade Brasileira de Mastologia e membro do Departamento de Imagem da SBM. Ele tem título de especialista em mastologia e é professor colaborador da Faculdade de Medicina de Jundiaí. Os nossos palestrantes de hoje, a gente tem a primeira aula, Vigilância Mamográfica em pacientes com câncer de mama após os 50 anos ou mais, um resultado do estudo MAMO50, de não inferioridade de mamografia anual versus menos frequente. Doutora Janet A Dunn, ela é Head of Cancer Trials na Warwick Clinical Trials Unit, na Warwick Medical School, expert in clinical trial design, focusing on cancer research and practice-changing studies, lead researcher for the MAMO50 non-inferiority trial comparing annual versus less frequent mammography, contributor to advancing breast cancer screening practices through evidence-based clinical trials. Segunda palestra, nós temos a adição da mamografia com contraste à tomossíntese para a detecção de câncer de mama em mulheres com histórico pessoal de câncer de mama, o estudo TOCEM, onde temos a pesquisadora a doutora Wendie A, que é Professor of Radiology at UPMC and Principal Investigator of ACRIN 6666 on breast imaging in high-risk women, MD and PhD from Johns Hopkins, and co-author of BIRADS lexicons and over 100 publications. Leader of clinical trials on advanced breast imaging, including contrast-enhanced mammography studies. Recipient at multiple awards for breast cancer research and chief scientific advisor to dancebreastinfo.org. E a última aula, Imagem com contraste da mama, da mamografia à ressonância magnética, onde temos Charbel Saade, Global Director of Education and Co-Engagement of GERBIT, with expertise in X-ray, CT, and MRI, lecturer and at international congresses and co-author of over 250 papers and 350 abstracts on contrasted media enhanced patterns in disease, adjunct senior lecturer of medical imaging at University College Cork and external examiner at University College Dublin, advisory board member at Gulf Medical University, contributing to medical imaging advances. Welcome all.
So thank you to the organisers for inviting me to present the results of MAMO50. MAMO50 is a non-inferiority trial of annual versus less frequent mammography for women with early breast cancer, aged 50 years or over at presentation. So I'm presenting this on behalf of the co-investigators for the MAMO50 trial. So I have no conflicts of interest. So the background to the trial, the current guidelines in the USA and Europe recommend annual surveillance mammograms for an unspecified period of time after treatment for early breast cancer. Our current UK guidelines recommend annual surveillance mammograms up to 5 years, and then it reverts back to the UK 3-yearly screening programme without specified risk stratification. We know that annual mammograms are a significant cost burden to the healthcare system and causes anxiety to some patients. So further evidence was needed to determine the optimum frequency and duration of mammographic surveillance, and this was commissioned, a commission call from the UK NIHR UK government funding body. So the design of the Mama 50 trial, you had to be eligible. To be eligible, you had to be women over the age of 50 at diagnosis, having undergone previous treatment with curative intent for invasive or non-invasive breast cancer, and you had to be 3 years post-curative surgery. Prior to randomisation, all women had a baseline mammogram and then were randomised to annual mammograms, continuing for further 6 years, up to 9 years post-diagnosis, or less frequent mammograms. The less frequent schedule was 2 yearly if women had undergone a wide local excision, or 3 yearly if they had undergone mastectomy. So the primary outcomes for the trial were breast cancer specific survival and cost effectiveness, with secondary outcomes being recurrence-free interval and overall survival. Within the study, we had a very popular quality of life sub-study using these 4 different quality of life scales. So the distress thermometer, the assessment of survivor concern, Warwick and Edinburgh wellbeing and mental health and wellbeing scale, and the FACT-B. And these quality of life scales were collected annually. So within the trial, we needed 5,000 women to detect a 3% absolute non-inferiority margin for the breast cancer specific survival primary outcome. And we could do this with a 85% power. The primary analysis was carried out on an intention to treat basis with a sensitivity analysis per protocol for the per protocol population. So what did we find? So we recruited 5,235 women randomised between April 14 and September 18. You can see from the patient characteristics that the majority of people, or a lot of the most common age group was 60 to 70, with about a quarter being under 60 and 3/4 being over 60 years old. 80% had wide local excision surgery and 20% mastectomy, and 87% had invasive disease and 13% DCIS. So of the 4,569 patients with invasive disease, the tumour characteristics are as shown. So the majority had smaller tumours, about half of them were grade 2. We had 75% were node negative, and we had 82% of patients were ER, PGR positive or HER2 negative. But just to note, we did have 6% triple negatives, and we did have 12% HER2 positives entered into the trial. So at the time of the data lock, which was October 23, our median follow-up was 5.7 years. Remember, this is patients are randomised 3 years post-diagnosis, so this is a median follow-up of 8.7 years post-curative surgery. 7%, at this time, 7% of women had died, with 343 events, 116 of these being breast cancer specific events, 93 other cancers and 134 other causes. 7% of patients had invasive breast cancer recurrence, and again 103 local regional recurrences, 102 new breast primaries, and half of them, 192, having distant recurrences, with 5% having non-new breast malignancies. These were mainly skin, lung, colorectal and gynae. So primary outcome of breast cancer specific survival, we have annual arm shown here in the blue line and less frequent arm shown in the red line. And we have as you can see, we have a purple line. So we've demonstrated non-inferiority of less frequent mammograms at the pre-planned 3% margin, but also at the 1% margin. And you can see here the 5-year breast cancer specific survival rates were 98.1% in the annual arm and 98.3% in the less frequent arm. This gives us a hazard ratio of 0.92. Similar results for the relapse-free interval. Now we've got slightly more events, and our 5-year rates are 94.1 compared to 94.5 with a hazard ratio of 1. We've demonstrated non-inferiority of relapse-free interval at the 2% margin. And again, you can see the lines are nearly giving us a purple line. And for overall survival, again, we've demonstrated non-inferiority for less frequent mammograms at the 2% margin. And here we've got 167, 176 events as shown. 94.7% 5-year overall survival in the annual arm, 94.5% 5-year survival in the less frequent arm. Now the hazard ratio is 1.08. So we demonstrated for all of these outcomes non-inferiority of the less frequent arm. But it's important to look at compliance. And in this study, we had 15,967 mammograms performed on the annual arm and just slightly more than half on the less frequent arm. 83% of women on the annual arm complied with the allocated schedule compared to 69% on the less frequent arm. And as you can look at the reasons for non-compliance, the annual arm had more chance of missing mammograms, and that's occurred in 12%. And the less frequent arm had more chance of having additional mammograms. That happened in 15%. This gives us an overall compliance of 76% for the study. And it's important to just look at that 76% because the 3,987 patients who fully complied form the population for our sensitivity analysis of per population analysis. So we knew that COVID was going to affect compliance. Luckily, it only affected missed mammograms in 35% of those who did miss a mammogram. Since the data lock, we've also linked to the UK National Screening data. At the time we started Mama 50, there wasn't a mechanism within the screening service to temporarily suspend patients from being invited to go to screening. And so we did consent the women not to attend any screening invites, but we found that we did have 2.5% of women did actually attend screening. So we found another 132 more mammograms, and we're just in the process of putting these into the right categories. But it's important to, as I've said, for that population that complied, conclusions remained absolutely unchanged after the sensitivity analysis of this complied population. So the other thing that we did, as I've said, we had a quality of life subgroup sub-study, and out of the 4 scales, there was no difference whatsoever across the 2 trial arms in any of the 4 scales. But we thought it was interesting to look at the distress thermometer pre-randomization, so at baseline. And you can see here, 30%, so a third of all of the patients had no distress to report whatsoever, with another 46% reporting low levels of distress, 18% median levels, but 6% presenting high levels of distress. The distress thermometer goes from 0 to 10, and these are patients reporting 8, 9, and 10 levels of distress. So we had a look to see what the reasons were, and it shouldn't surprise you that the reasons for these high levels of distress were mainly, or we would say mainly, associated with ongoing hormone therapy. So half of these patients with high levels of distress had fatigue, exhaustion, or extreme tiredness. Again, just over half sleep problems and or nightmares. 50% had worry, fear, or anxiety, and hot flush, followed by 41% hot flushes, and then memory loss, concentration, pain, or sadness or depression. And as I've already said, there was no difference between these high levels of distress across the treatment arms. And here you can see all levels for the annual arm and for the less frequent. So in conclusion, Mama 50 demonstrated that for patients aged 50 years or older and 3 years post-diagnosis, less frequent mammograms were non-inferior to annual mammograms. But we would say, looking at some of the quality of life measures, there is a need to have a mechanism for easy access back into the system for symptom management and for ongoing support. We would say that Mama 50 provides evidence for changing clinical practice. So what next? So the trial outcome paper is under review with the Lancet, and fingers crossed that will be published soon. We've completed the detailed quality of life and qualitative paper. Within the qualitative paper, we have lots of free text fields. We did ask patients if they wanted to tell us anything else that that they thought was important about their patient journey. So we've got 3,000 free text fields that have been categorised, and that's quite an interesting paper. The health economic analysis paper was delayed because of access to data linkage, but that's now nearly complete. And there's lots more papers to come, because this is a unique population of patients. They're 3 years post-diagnosis. They have no sort of indication of disease when they were randomized to this study. And so, you know, you can follow these patients up, and it's much more a survivorship kind of situation than newly diagnosed patients and initial treatment. So I'd like to acknowledge and say thank you to all the 115 UK recruiting centres and the Mama 50 trial team, with special thanks to all the women who took part in the Mama 50 trial. And I'd like to thank you for listening, and feel free to email me if you want access to the slide set, or you've got any other questions. Thank you.
Good morning. I'm Dr. Wendie Berg, and I'm going to be talking about using contrast-enhanced mammography for screening women who have a personal history of breast cancer, specifically results from our TOCEM trial, where we're also doing tomosynthesis. Here are my disclosures. In general, I'm going to be talking about using contrast mammography in women with personal history of breast cancer, looking at cancer detection rates and false positive rates. I'll be comparing those results with ultrasound and MRI. And I also want to just touch on ongoing studies and further questions that need to be addressed. By way of background, I'm sure you all know that there is reduced mammographic performance in women who have a personal history of breast cancer, with higher symptomatic interval cancer rates, especially if the breasts are dense or if the woman was diagnosed with breast cancer before the age of 50. In those women, supplemental screening with MRI has been recommended, but it is not well tolerated by all women, and contrast mammography, or CEM, appears to be a reasonable alternative to MRI. Across multiple studies using MRI in women with personal history, we see a cancer detection rate from MRI of an additional approximately 12.6 per thousand, additional recall rate of about 10%, and the PPV3 of biopsies performed of about 28%. These are very reasonable numbers, and that's certainly a high added cancer detection rate. Mammography alone finding about 5 cancers per thousand. But we also have issues with MRI in that there's a limited capacity for screening MRI, even if we use the abbreviated or shortened protocol, and not every patient can tolerate an MRI. Some women have claustrophobia, or have exceeded the weight limit of the table, or have pacemaker or other hardware that is incompatible with MRI, or may be pregnant. We also know from the Akron 6666 study that about 42% of women offered an MRI, even at no cost, declined. And about 41% of women in the DENSE trial in the Netherlands also did not participate in an MRI at no cost. So there's a substantial number of women for whom MRI is not a great option. CEM does require injection, IV injection of iodinated contrast, the same contrast that's used in CT scanning. It gives a patient a warm feeling all over with a metallic taste in their mouth. There's a small risk, less than 1%, of having an allergic type contrast reaction or even anaphylactic. The most common reaction is hives, but the staff do need to be trained in contrast reactions. It's the same positioning as a mammogram. There are 2 exposures obtained, one at low energy that mimics a standard mammogram, and one at high energy, where predominantly the iodine absorbs the X-ray, and the radiation dose is therefore about twice that of a standard mammogram. The images are then processed with subtraction of the low energy from the high energy images, showing only what is enhancing. There are several studies, including our own, that showed about 70% of women prefer contrast mammogram to an MRI. This is particularly true if they have a history of claustrophobia. Across several studies, including our own that was just published, the interim analysis was just published in Radiology and earlier this year, the overall added cancer yield was about 9.6 per thousand from CEM, with a false positive recall rate of about 4% and a PPV of biopsies of 31%. Very similar results to MRI, but with an overall lower false positive rate. So I want to talk in a little bit more detail about our study, the TOCEM study. In this study, we have enrolled 1,647 women for 3 annual rounds of CEM and tomosynthesis. It's an asymptomatic population. It's their routine annual exam, and they have to have adequate kidney function and have at least one native breast without an implant. Every exam is double read by 2 radiologists, among 15 total. The first reader looks at the tomosynthesis first and records results, and the second looks at CEM first. And then the reader 1 has the final say on recall or not after integration of the results between the 2 readers. Beginning in April of 2021, we had CEM guided biopsy available. Prior to that, we used MRI guided biopsy when needed. And across the patients to date who've had multiple rounds of screening, in the first year, we had an added cancer detection rate from CEM of 7.1 per thousand. Not surprisingly, the added cancer detection rate in years 2 and 3 was lower at 3.8 per thousand. The overall sensitivity in year 1 of the women who had 12-month follow-up of tomosynthesis sensitivity was about 56% compared to 81% or so with the combination. That was significantly higher after adding CEM. And the sensitivity in years 2 and 3 was even lower for tomosynthesis, but with a comparable added yield from CEM. We saw a benefit to adding CEM across all breast densities, even scattered fibroglandular density. There was a substantial proportion of cancers that were seen only on CEM. We saw a similar benefit if we looked only at women who were diagnosed before age 50 or had dense breasts. A little bit higher yield in those women at 15 per thousand compared to only about 11 per thousand if they were over age 50, but still a substantial rate. So there's no population that we would exclude from having CEM. Here's an example of a 32-year-old woman who had prior right breast conserving therapy 4 years earlier and had a left breast papilloma. You can see the tomosynthesis shows dense tissue and no suspicious findings. On contrast mammography, there is an enhancing irregular mass adjacent to the clip that was at the site of papilloma. Targeted ultrasound was performed, showing that irregular mass in the retroareolar left breast, and this was a grade 2 invasive ductal cancer, ER/PR positive, HER2 negative, measuring 1.7 centimeter at mastectomy with negative sentinel lymph nodes. Here's another patient in the second year of the study. She had prior breast conserving therapy 11 years earlier for an ER/PR positive tumor. She has only scattered fibroglandular density, and there's nothing suspicious on the mammogram. But on contrast mammography, there's a new oval, low conspicuity enhancing mass in the outer left breast. This was before we had CEM guided biopsy, and she had an MRI guided biopsy that showed an 8 millimeter triple negative invasive ductal cancer that was seen only on CEM. Another patient in the study who had prior breast conserving therapy on the right side, 19 years earlier, had a few calcifications noted in the left breast. And here's the magnification or close-up of the tomosynthesis slice showing a few linear calcifications, but nothing else was seen. On magnification, there were a few additional amorphous calcifications noted. She had biopsy of both sites, and the linear calcifications proved to be ER/PR positive DCIS. The more anterior calcifications were atypical ductal hyperplasia. On CEM, there was only on the CC view, there was an enhancing mass in the retrorelar left breast. Interestingly, there was no enhancement at the site of the calcifications that proved to be DCIS. That's not uncommon. And so the retrorelar mass underwent ultrasound and proved to be a high-grade ER/PR positive invasive ductal carcinoma measuring 2.1 centimeter. So she ultimately had both areas excised. Of the cancers that were seen only on CEM, 72% were invasive. The median size was very small at only 6 millimeter, and only one of the tumors seen only on CEM was node positive. The vast majority were stage 1 or stage 0. In terms of recall rates, there was, of course, additional recall prompted by CEM, averaging 6.6% in the first year and down to 5% in subsequent years when we had prior exams for comparison. There was also a slight decrease in the PPV of biopsies. And overall, a cumulative false positive biopsy rate was about 1.6% from tomosynthesis and 4.1% from the combination of tomosynthesis and CEM over the 3 years of the study, which is not so bad. Here's an example of a false positive exam. This patient had multiple irregular masses developing, including at the scar, but also elsewhere in her breast, scattered density, and these all enhanced and ultimately underwent ultrasound-guided biopsy and proved to be a fat necrosis. There were 3 interval cancers to date. One was at the scar and was falsely attributed to the scar. 2 were actually in the axilla and not included in mammographic positioning. Here's the scar case that on the tomosynthesis, there was nothing to see. In retrospect, on the CEM, there is subtle enhancement that's just deep to the skin, but it could easily be post-surgical scar and fat necrosis. But 6 months later, she had a palpable thickening at the scar, and this was an invasive lobular carcinoma recurrence. This is one of the false negatives in the axilla, where she'd actually had a biopsy of this lymph node years ago with benign result. You can see the clip. It wasn't even included on the CEM exam, and ultimately she had a palpable mass 6 months later in the axilla that proved to be a recurrent disease in that lymph node, so a difficult case. There are some implementation issues. I mentioned already that staff need to be trained in iodinated contrast reactions. IV needs to be started. We have a nurse doing that for us, and there is sometimes an issue with patients not having IV access if they've had prior breast cancer and lymph node surgery and they don't always have the best veins. We do have to check kidney function if the patient is over age 60 or has risks for reduced kidney function like hypertension. And in the United States, CEM is only currently FDA approved for diagnostic imaging. Not all women can tolerate an IV, and this is just one of these analyses. But if they are concerned about false negatives, then they're more likely to tolerate an IV injection. Ultrasound does need to be considered as an alternative, but unfortunately has relatively less cancer detection. In the Akron study, we found a yield of only 4 per 1,000 adding ultrasound to mammogram in women with personal history, and there was a substantial and higher false positive rate of 8%. Here's just one example of an irregular mass seen only on ultrasound in a woman with prior right mastectomy. And this was a high-grade invasive ductal cancer seen on ultrasound. Just comparing across modalities, and we're almost finished here, the yield from MRI in Christian Kuhl's analysis in women with dense breasts averaged about 12 per 1,000 compared to only about 10 per 1,000 with CEM and 3 per 1,000 with ultrasound. The differences between MRI and CEM are quite small. Specificity may be better with CEM, but time will tell. Certainly, ultrasound has both lower cancer yield and lower specificity. So, there are some questions about how long to continue this. Do we keep doing annual CEM every year? Do we stop screening at any point? In the United States, we do keep screening indefinitely as long as the woman's otherwise in good health. But one big question is whether we need to do CEM every year or perhaps every other year will be sufficient. And we are in the process of doing a biennial TOCEM study now. So to summarize, annual MRI is currently recommended if women have a personal history of breast cancer, were diagnosed by age 50 or have dense breasts, or are otherwise at high risk because of a known disease-causing mutation. Probably if they've had invasive lobular cancer, we're more inclined to do screening MRI as well. It should be considered otherwise, but is not generally recommended beyond age 70. We did find in our study and in several others that have been published that women with a personal history of breast cancer, CEM screening is a good alternative to MRI. It can be done as a diagnostic exam, even if it's a routine annual exam in the United States, and bill for the contrast. We do encourage inclusion of as much axillary tissue as possible. Screening ultrasound can be done when neither MRI or CEM is an option or desired. Some patients really don't have IV access or prefer not to have any contrast injection, but we expect lower benefit to that. And there's no benefit to surveillance imaging after bilateral mastectomy, even if the patient's had reconstruction. Thank you for your attention.
Hi, and welcome to this lecture on contrast-enhanced breast imaging, principles, techniques, and applications. Firstly, thank you so much to the Breastmit Congress and wishing you all a fantastic Congress, and thank you for inviting me to present. My name is Dr. Charbel Saade. I'm the Global Director of Education and KOL Engagement, as well as a Professor of Radiology. So just a disclaimer, I am a Gurbet employee. So regarding the pharmaceutical products and medical devices mentioned in this presentation, please refer to their local summary of characteristics and/or the instructions for use. Trademarks are the property of their respective owners. This lecture will discuss vascular anatomy, contrast media bolus geometry, blood supply to the glandular tissue, and CE and breast MRI clinical cases and protocols. So first, let's start off with the arterial blood supply to the breast tissue. As you can see here, whenever you're looking at the axillary artery, there are basically two major routes or points of supply to the actual breast tissue. Number one, you have the lateral thoracic artery, which provides to the lateral segment of the glandular tissue. And then you have your internal mammary artery, which actually supplies 75% to the medial border of the breast tissue and probably most of the blood supply to that area. Now, interestingly, also the lateral mammary branches and the medial mammary branches, they do have areas of anastomosis. And then if we go into the venous system, the drainage goes back to the internal thoracic vein and of course to the afferent mammary vein as well, and drains back into either the left external jugular vein, or it will go directly into the brachiocephalic vein. Now, if we look at the nipple and areola complex blood supply, we know already that the lateral thoracic artery probably supplies about 16% of the blood supply to the breast tissue. It is the internal thoracic artery which supplies 73%, and of course the anterior intercostal artery provides the inferior segment below the areola in about 4%. Interestingly also, whenever you're having these various blood supplies, this then takes us to how we understand contrast media delivery in the breast. Now let's look at blood supply to the glandular tissue, and this is where it starts to get interesting. And then the complexity gets even worse, because normally if you look at the image to your right, you have your normal mammary duct and you have your terminal lobular unit. But if you can look at the actual blood supply, the capillary, it's like a uniform cobweb that goes all the way around the terminal unit. However, the image to your left, if you begin to have a lesion, then you're going to get a complex angioarchitecture, because the vascular endothelial growth factor recruits blood vessels into the lesions directly. And this is where you'll have different sizes. So in assumption, that the contrast which enters the arterial system is going to be uniformly spread on the lesion, is not going to be accurate at all, because you have complex diameters, lengths, and pressures in each of these vascular territories. And then if we're looking at neoplastic growth, every lesion at different point in time, for example, if I look at normal epithelium, you'll have your mammary stem cells, your basal cells, your adipocytes, fibroblasts, macrophages, and endothelial cells. They're uniformly there. And that's why when we're looking at contrast enhanced mammography or breast MRI with contrast, we always use subtraction. However, if you start to get intraductal hyperplasia, this is where your HR plus and minus luminal cells start to increase and narrowing this area, and it becomes more difficult. But it's only until you get to intraductal hyperplasia with atypia or ductal carcinoma in situ or invasive carcinoma, this is where the vascular supply begins to change and your enhancement patterns can vary. So whilst people might think, oh, just inject contrast and then we wait at a certain time, well, there's a few things that we need to take into consideration. So it's the vascular supply to the lesion, depending on if it's early or advanced. Number two, we look at, of course, the patient's stroke volume of their heart, and usually you can determine this quite easily. And then number three is your technique. Now, when we're looking at our technique of contrast enhanced mammography, these are the world guidelines that people like to use and follow. And if you're looking also at, what density of contrast to use, currently in literature, nothing has been presented yet. However, 350 density seems to be the ideal standard. We like to use 100 mils of contrast and 100 mils of saline and inject at 3 mils a second. When we go into the technique, we always remember that contrast enhanced mammography is really based on scattered radiation. So we're not using high energy imaging, so you don't really need the high iodine concentration. Number two, if you're looking at the K-edge of contrast, and later we'll go into the parameters, you can actually see that breast tissue with iodine has a similar enhancement profile. That's why subtraction is always ideal. And the K-edge of iodine is at 33.2 kilo electron volts. So how does this all work? Quite simply, whenever you do your pre-contrast or your scout or your baseline image, and then of course you do your next image at 2 minutes, 3 minutes, 4, 5, and 6 minutes. Keeping in mind that you will do corneocranial MLO, and we'll talk about them in a moment. And then you'll also do right breast versus left breast. So the critical thing here is, whilst you're going to use 100 mils of contrast, also using the 100 mils of saline is critical because it prolongs that opacification profile, so you can get into those very complex angioarchitectures and you can enhance that lesion uniformly. A typical scanning protocol, usually you have low and a high KEV or KVP energy range. So it's usually between 26 and 33.2, whereas if you have the high one, it's at 44 to 50 kVp. Now remember, this is all dose weight modulated as per their manufacturer's instruction. And then you start to look at the average glandular tissue and the dose per breast and the average glandular dose per image, because whilst we can do so many more images, remember, glandular tissue is very radiosensitive. So when we're looking at the radiographic views, at 2 minutes, you do a high energy versus a low energy. It could be CC, craniocaudal of the affected breast at 2 minutes. Then at 3 minutes, you'll swap to the other side. You do one high energy, one low energy, of course, which allows for subtraction. And then you do an MLO of the affected breast versus MLO of the normal breast. And we know that the iodinated contrast media half-life, radiological half-life, is 3 minutes. So usually it's the first two sequences are the most important sequences. And then, of course, the last two is to see if there is persistent enhancement or not. Now, when you're looking at lesions between suspicious versus non-suspicious, usually they like to look at, cranial caudal for non-suspicious, but they've also found that cranial caudal for suspicious lesions tend to yield the best results in terms of detection. So this is critical here when you're looking at pathology-orientated acquisition order. CC, whether it is suspicious versus non-suspicious, is usually outperforms the medial lateral oblique. And then the next item that we need to pay attention to is background parenchymal enhancement, and this is critical for both contrast enhanced mammography as well as breast MRI. Now, if you're looking at this, you have your enhancement is said to be present if a finding has a greater uptake of contrast agent than the background parenchyma. Enhancing lesions may be missed with increased background parenchymal enhancement, which is similar to MRI. Now, although malignant lesions show contrast enhancement, many benign lesions do as well. So just because you do get enhancement, it's not necessarily malignant. And common benign causes of enhancement include atypical ductal hyperplasia, which we talked about before, benign fibrous breast tissue, fibroadenoma, infection or inflammation, papilloma, pseudoangiomatosis, stromal hyperplasia, radial scar or complex sclerosing lesion, and spindle cell proliferation. So remember before when we were going through the different stages of lesions and neoplasia, it really depends on what stage you'll have different enhancement patterns. And then finally, some cancers can have little or no enhancement on contrast enhanced mammography, and lack of enhancement on breast cancer is a rare phenomenon that also has been reported with MI and can cause a false negative result. So something to really be careful about. And the degree of BPE, or background parenchymal enhancement, this represents how much the normal tissue is impregnated after contrast media injection and depends on several factors. Number one is tissue vascularity and permeability. Endogenous and exogenous hormones, this is critical. So if you're on hormone therapy, you're going to have increased background parenchymal enhancement. And if you're on endocrine therapy as well, it increases background parenchymal enhancement. So when do we image? So normally the breast is hormonally sensitive tissue and undergoes involutional changes as women age and hormone levels decrease. This may be why postmenopausal women who are exposed to lower estrogenic hormone levels have a lower background parenchymal enhancement during contrast enhanced mammography. Now, BPE level does not fluctuate significantly according to the menstrual cycle time. So if you have a look here at the menstrual cycle timing graph, you can actually see between days 15 to 28, it's the highest, whereas day 1 to 14 is usually the lowest. So if we take a look here, this is your typical study. A patient had a large lesion. They were called back for contrast enhanced mammography, and as you can see, it was a false positive. Here is another patient that you had one close to the pectoralis major wall. When they did subtraction, it wasn't there. And then when they zoomed up, they saw actually this large speculated environment, and this was an invasive ductal carcinoma. Let's now take a look at a few cases. So here is a typical 63-year-old female with 2 months left lumpectomy for invasive lobular carcinoma. She has a spiculated mass adjacent to the chest wall, intermediate T2 signal, intermediate T2 weighted, fat suppression signal, and intermediate T1 weighted sequence. As you can see, it's gone into the chest wall, and we put saturation bands away because, again, remember at the pectoralis major muscle, you can have lesions that present there. So what happened was when they did this enhancement, we gave gadolinium. It definitely showed as if it's an invasive lobular carcinoma. And then when we also did the dynamic enhancement, you can actually see it was prolonged and it kept filling and it kept rising. So it was a slow progressive enhancement type 1A. If you're looking at contrast-enhanced mammography or contrast-enhanced MRI compared to mammography, the sensitivity and specificity is always going to be a lot higher compared to, mammography or ultrasound. That's why MRI is really critical. Now, if you're looking also at contrast-enhanced mammography, it can help as well if you don't have access to an MRI. And this is where the beauty is. Another thing I want to add also is it is really important that if you are to do contrast-enhanced mammography, you have the software application on your mammography unit. Otherwise, you'd need to go to MRI, or again, you could also use ultrasound. And remember, the reason why you're having these variations in ultrasound is because it's user dependent. So in this lecture, we discussed vascular anatomy, contrast media bolus geometry, blood supply to the glandular tissue, and breast MRI and contrast enhanced mammography cases. So thank you all very much, and congratulations to the Breastmit team. I wish you all a fantastic Congress. Use this QR code, scan the QR code. Every month we run 2 webinars. It's free to join, and you have 5 world bodies that certify our education program. It's free to join, and more importantly, you'll get a certificate and help shape radiology for the better. So thank you all very much, and I wish you all a great Congress ahead.
Bom, depois de aulas brilhantes, né? Muito obrigada aos 3 palestrantes. É um prazer para mim ouvi-los. Doutora Wendie A é uma pessoa que há muitos anos eu venho seguindo, né? A gente vai lendo e hoje estar aqui numa mesa com ela, para mim é um privilégio. Muito obrigada. Eu gostaria de ouvir os nossos palestrantes, os nossos debatedores, né? Vamos começar com o Dr. Rodrigo Pepe, por favor, fazer suas considerações.
Bom dia, Thais, obrigado. Bom dia a todos, Tereza, todos que estão na audiência de hoje. Mais um grande evento capitaneado aí pelo Henrique, pelo time de Minas Gerais, excepcional para o Brasil e para o mundo, mostrando nosso interesse, nossa qualidade em termos de pesquisas e trabalhos com imagem da mama. Realmente, como você falou, Thais, é muito interessante a gente assistir essas apresentações, que vai de encontro a algumas coisas que nós temos conversado em outros eventos da sociedade, da mastologia, tanto na sociedade quanto no grupo de mama da mastologia. A importância do rastreamento, na verdade, do acompanhamento das mulheres com câncer de mama é muito importante. A gente tem hoje as recomendações recentes, atualizadas, da Comissão de Mamografia, né, do Colégio Brasileiro de Radiologia, da FEBRASME, da Sociedade Brasileira de Mastologia, que mostram essas recomendações de segmento, as quais, particularmente, eu sigo de maneira bem precisa com relação ao follow-up dessas pacientes que tiveram câncer de mama. Então, permanecem com mamografias anuais e com ressonância intercalada, de acordo com a característica de cada mulher. Agora, esses trabalhos, principalmente esses relacionados à mamografia com contraste, que é um tema que eu gosto muito, acho muito interessante. Alguns anos atrás, o Colégio Americano de Cirurgiões de Mama, Sociedade Americana de Cirurgiões de Mama, recomenda, nas suas recomendações de screening, que a mamografia deve ser feita anual, se possível, com tomossíntese. A Comissão de Mamografia aqui do Brasil, com essas 3 especialidades que eu citei, seguiu o mesmo caminho, dizendo que sempre que fosse disponível a tomossíntese, que ela fosse utilizada para o acompanhamento das pacientes, rastreamento e acompanhamento das pacientes. E depois eu vi essa apresentação sobre a performance da mamografia com contraste, eu volto a perguntar para a nossa sociedade, para a nossa comissão de imagem, e eu não tenho o poder hoje de perguntar para a Sociedade de Cirurgiões de Mama, se não é hora de começar a incluir nas opções a mamografia com contraste ser disponível. Quer dizer, a performance dela é sempre superior quando comparada com a mamografia, é muito similar quando comparada com a ressonância, e é um procedimento mais rápido, mais barato e mais bem tolerável para nossas pacientes. E agora, com a possibilidade de você fazer uma abordagem cirúrgica, uma mamotomia orientada também pela mamografia com contraste, eu não vejo por que a gente não incluí-la na nossa rotina. Então, eu acho que é hora da gente fazer uma virada, como fizemos há alguns anos com a tomossíntese, começar a fazer uma virada também com relação à mamografia com contraste. É um método excepcional, uma performance excepcional e um benefício, sem dúvida nenhuma, muito grande para todas as nossas pacientes. Pensando especificamente no Brasil, a gente tem muita dificuldade nos serviços públicos, de um modo geral, para ter mamografia de qualidade, muito mais difícil para que a gente possa ter uma ressonância. Mas esse investimento, em algum momento, precisa ser feito no nosso Sistema Único de Saúde. E a conversa que nós já tivemos outras vezes, se não é mais fácil e mais barato e com uma performance absolutamente fantástica, incluir no nosso sistema de saúde a mamografia com contraste, ao invés da ressonância. É um método mais barato para o sistema, é um método mais bem tolerado, como eu falei, com uma performance fantástica. Então, na verdade, são só comentários, assim, e agradecer muito a apresentação, principalmente da doutora Wendie, que mostrou isso para a gente de maneira muito clara, onde a mamografia com contraste é um método cada vez mais presente na nossa rotina, e eu espero que seja um método também acessível para a nossa população em pouco tempo.
Obrigada, Rodrigo. Realmente, os métodos funcionais, eles vêm para ter um papel muito importante, né? Principalmente nesse cenário da paciente de alto risco, né? Que a doutora Wendie fala tanto para a gente, quanto na paciente pós-tratamento. Então, gostaria de ouvir a doutora Tereza com seus comentários, por favor.
Primeiro, eu quero agradecer o convite para o Breastmit, assim, e maravilhoso evento. E muito emocionada por estar aqui com a doutora Berg, que eu sou fã há muitos anos, acompanho os trabalhos todos, leio, gosto demais. Queria agradecer de coração a sua presença, porque engrandece muito o nosso evento. E algo que eu queria falar é que o nosso país ele é um pouquinho assim, diferente, porque nós temos muito câncer de mama em pacientes jovens. Então, nós temos muita essa dificuldade com mamas mais jovens, com mamas mais densas. Então, nesse cenário, a mamografia com contraste, ela veio trazer para a gente uma luz, porque o nosso país é um país pobre. Então, assim, o acesso à ressonância magnética, ele não é para todos. A gente tem dificuldade de acesso à mamografia. A mamografia convencional, grande parte do nosso país tem dificuldade de acesso. Então, assim, falar que nós vamos ter acesso à ressonância magnética para ajudar no rastreamento dessas mulheres jovens com mamas densas que tiveram câncer, é pensar que não vai ser por agora. Então, o que a gente pode ajudar essas mulheres? Com a mamografia com contraste, eu acho que é uma ajuda, assim, maravilhosa para o nosso país. Eu acho que a gente tem que implementar isso aqui. E uma coisa que eu queria te perguntar é sobre a biópsia, porque normalmente quando a gente faz aqui muito ultrassom de mamas, nós temos muita experiência com ultrassom de mamas. Então, normalmente, quando achamos uma lesão na ressonância, em grande parte das vezes a gente consegue fazer essa biópsia guiada por ultrassom. Mas quando acharmos uma lesão só na mamografia com contraste, a gente ainda não tem tantas, eu pelo menos não tenho tanta experiência em fazer a biópsia guiada por mamografia com contraste. Eu gostaria de perguntar se tecnicamente é tranquilo de ser feito, e como são os resultados, e como que os pacientes toleram. É isso.
Obrigado. In the contrast mammogram findings, about half of the time we can see things with ultrasound, or sometimes in retrospect when we review the tomosynthesis that we have also done on the same patients they can get tomosynthesis at the same compression as the contrast mammogram. And that can be helpful that we see subtle distortion in retrospect. But about half of the time we do need to use direct contrast methods to do the biopsy. It can be done under MRI, but even though we use MRI, we also have access issues in the United States. It is about a 2-month delay now for us to get an MRI-guided biopsy because we do not have enough capacity either. And so it is important, if you do contrast mammography, to have direct contrast mammography guided biopsy. It is relatively easy to do, but I think there is still room for improvement. Sometimes lesions are harder to see than they should be. And I've been surprised at the low conspicuity, how hard it is to see some cancers with contrast mammography. Some very subtle findings will turn out to be cancer, and it can be a little bit challenging to biopsy them. We especially have been using contrast mammography after MRI initial detection of findings and trying to do biopsy using the contrast mammogram, and that has been particularly problematic. So I think there are times when you do need to certainly be prepared for contrast mammography guided biopsy if you're going to do contrast mammography screening. And if you can't always see it that way, then perhaps an MRI guided biopsy as a backup. But usually, I don't think for things we found initially with contrast mammogram, I think we're always able to see them and do the biopsy under contrast mammogram guided biopsy, but it still can be technically a little bit challenging.
Muito obrigada, doutora Berg. Eu gostaria de saber se o doutor Roberto está aí. Eu não ouvi. Ah, que pena. Então, eu acho que eu vou só agradecer, né, a participação de todos, né, estou assim muito feliz de estar dividindo uma mesa com pessoas tão importantes, né, para mim na minha formação. Doutora Wendie A, de longe, ela não tem ideia o tanto que ela me fez bem nos meus estudos de ressonância magnética. Os estudos dela são sempre muito presentes e ela é sempre uma fortaleza para a gente, quando a gente precisa mostrar para as pessoas que a gente acredita em ressonância e acredita no rastreamento de paciente de alto risco guiado por ressonância. Muito obrigada. Viu, Tereza, uma grande amiga, obrigada pela parceria nessa jornada. Pepe, muito obrigada. Vamos dar continuidade ao evento brilhante, um evento vanguardista, né, que traz para a gente o melhor de procedimentos minimamente invasivos e novas técnicas no cenário do câncer de mama no mundo. Queria só falar com vocês, por último, nós estamos com mais de 1.100 médicos online, mais de 30 países assistindo a gente. Então, é um evento grandioso e eu queria parabenizar a organização, principalmente o meu amigo Henrique Lima, que realmente nós estamos assim, muito felizes de estar participando aqui. Muito obrigada.
Thais, muito obrigado, doutora Wendie, mas eu tenho uma boa notícia, nós estamos, me corrige aí o pessoal da produção, mas a gente tem um pouco mais de tempo para o debate, se eu não me engano, a próxima mesa, ela está para começar às 9h55, então eu quero aproveitar, doutora Wendie,
se podemos.
E podemos estender e fazer mais algumas perguntas para a senhora. Essa mesa foi contrastante, porque, de um lado, na primeira apresentação brilhante da doutora Janet, a questão de descalonar e de reduzir a vigilância pós-tratamento. E, de outro lado, nós temos a questão de escalonar a vigilância e escalonar essa vigilância pós-tratamento. Nitidamente, nós temos um desafio que é melhorar os nossos números necessários para tratar. Esse é um problema na oncologia de forma geral. Então, como seguir essa personalização e como não misturar essas coisas? Como é que a senhora se sente em descalonar o rastreamento em quem teve um carcinoma de mama luminal pós-menopausa, uma vez que nós estamos preconizando escalonar para quem teve cânceres mais avançados, mais agressivos?
I think that the presentation on the MAMO 50 trial was challenging. I did not see the stage distribution exactly between the two groups, but we do know that annual screening reduces the stage distribution, and that's true in all women, including those who have prior breast cancer. And lower stage distribution eventually will make a difference in outcomes, and it certainly will make a difference in terms of treatment that's necessary and the costs of treatment that are necessary. I think the approach that we are now starting to look at is doing annual tomosynthesis in women with a personal history of breast cancer, but only doing a contrast study, either contrast mammography or contrast MRI every other year, because the cancers that we find with contrast are so small and so early that it really does provide great benefit. Indeed, in the CMIS study that is looking at screening with contrast mammography, they do not allow women who've had an MRI in the prior 3 years to participate because it's so unlikely to find a cancer on contrast mammography in even 3 years after a prior MRI. And we also found only one patient with cancer in the TOCEM study who'd had a prior MRI in the previous 3 years. So I do think there's some opportunity for de-escalating the frequency of screening with contrast, but I don't think that we can de-escalate the frequency of any screening. I think we still need an annual mammogram. And I would caution, certainly in women who have a known disease-causing mutation like BRCA1, they should have at least every year with contrast because they are at higher risk for triple-negative disease. But keep in mind, even with a luminal cancer, it doesn't mean that the second cancer is going to be a luminal cancer. I showed that one patient who had a fairly early luminal A tumor and had a triple-negative cancer that we saw only on the contrast mammogram, and that was new in the second year of our screening study. It was probably good that we did an annual exam in her because it was only an 8mm triple-negative cancer that we found as a result of the contrast mammogram. So there's always a risk to de-escalating because no system is perfect in identifying those women who won't develop an aggressive cancer. We can't be sure of that in any population. And I know the UK in particular has very limited resources, and they're really trying to do risk reduction and trying to reduce the frequency of screening in certain populations. But I think that's very dangerous in general, because at best, even with risk assessment, we can only identify about 70% of women who are going to develop breast cancer, and that leaves about 30% at risk for having a later stage diagnosis if they're not screened as often.
Henrique, eu não sei o que a doutora Wendie pensa, mas essa pergunta sua, quando você faz esse comentário, me vem na cabeça que tudo vai ser para frente, talvez, você vai desescalonar ou escalonar uma seleção de grupos, né? O estudo Mammo 50, ele fala de uma população aí de 60, 70 anos em média, né? A maioria das pacientes são mais velhas. E o estudo com contrastada são pacientes mais jovens, então talvez isso seja um início para a gente começar a pensar qual subgrupo, mas eu concordo com o Dr. Wendie, quando a gente pensa no que a gente tem hoje de dados, a mamografia é anual, né? Não tem, é uma coisa muito, muito interessante, mas essa seleção de grupos talvez seja uma coisa que possa pensar mais para frente, fazer um descalonamento aí, mas por hora, mamografia anual.
Thais, posso fazer mais uma pergunta, aproveitando o nosso tempo, então?
Claro que você pode.
Primeiro, mais um comentário a respeito desse escalonamento. A última frase da doutora Wendie foi interessante, dizendo que no Reino Unido eles também têm limitação de recursos, né? Quer dizer, imagina que no Brasil, se a gente tem que pensar comparando os recursos do Reino Unido com o do Brasil, doutora Wendie, nós estamos muito, muito, muito longe de vocês ainda. Ainda temos muito que remar. Mas ainda a gente ainda luta, inclusive, contra os órgãos governamentais. A gente está terminando agora o nosso Outubro Rosa. A sociedade tem as indicações de screening, mamografia a partir dos 40 anos, anualmente para todas as mulheres. E os nossos órgãos governamentais ainda insistem em indicar mamografia bianual a partir dos 50 anos. E aqui no Brasil, a gente sabe que 40% dos cânceres são abaixo dos 50 anos. Então, a gente está deixando de rastrear muita mulher com câncer de mama no Brasil por conta disso. Só esse comentário. Mas eu queria lhe fazer uma pergunta. As indicações da mamografia com contraste, obviamente, vão aumentando cada vez mais, a cada novos estudos, novas indicações, novas aplicações para mamografia com contraste. E um estudo recente mostrou que, como a Tereza falou, hoje a gente, quando tem uma lesão na ressonância, a gente tenta fazer um second look de ultrassom para poder direcionar a biópsia pelo ultrassom, porque é uma biópsia mais rápida e mais barata para o sistema. E os últimos trabalhos de mamografia com contraste mostraram que a performance da mamografia com contraste para um second look de ressonância é muito superior à de ultrassom. Então, a gente consegue ver as lesões de ressonância com muito mais clareza no second look com mamografia com contraste do que com ultrassom. Eu confesso para a senhora, eu não tenho ideia de custo de uma biópsia orientada por mamografia com contraste quando comparada à biópsia orientada por ressonância. Aqui no Brasil, a biópsia por ressonância é muito mais cara do que uma biópsia por ultrassom ou por mamografia ou tomossíntese. Agora, eu não sei a mamografia com contraste, se isso vai ser também custo efetivo a gente orientar essas biópsias quando comparado com o custo da biópsia por ressonância.
Right. So I appreciate the discussion. We have found, as I mentioned, we have been trying to do contrast mammography guided biopsy of findings that we saw on MRI first, and we have only about a 60% success rate. So about 40% we cannot do the biopsy under contrast mammogram. Most of those failures were because we could not see the lesion. Sometimes we could see it on the initial CC and MLO mammogram images, but then when we tried to position in the stereotactic unit to do the biopsy, we were not able to see it anymore. So there are many challenges. Some centers will do a separate visit for the contrast mammogram to plan biopsy, and perhaps that would help if you knew exactly where to position and could just start out by positioning within the small window of the stereotactic unit at the time of biopsy. But we don't make the patient do 2 separate visits. And so it's a little bit more challenging sometimes to interpret it right away, to correlate with the MRI and to set it up. We did find there were just as many cancers in the group that failed. So it's not that if we don't see it, we cannot relax. We can't avoid doing a biopsy. I can speak to the cost is about the same as a stereotactic biopsy, with the exception of the added very small cost of the contrast, which is for us about $15 for the contrast dose is what we actually pay for the contrast. So it's in between an ultrasound biopsy and an MRI biopsy in terms of cost. It is generally, of course, much more cost effective to do the contrast mammogram when possible compared to MRI. And it is much easier to adapt mammography equipment than to install another MRI machine. So all of that makes a lot of sense to improve access for women. I agree. Younger women especially may benefit even more because it is more of an issue to do additional screening, and the cancers are more aggressive when they do happen. In a separate study that we've done and presented at RSNA but not yet published, it's been reviewed and I have to respond to reviewer comments. We did look at screening in women with dense breasts, and there was a very high recall rate in the perimenopausal patients, and overall it was actually about 13% recall rate from the contrast mammogram in women who have dense breasts and who were younger. It was actually as high as 20% recall rate in the perimenopausal women. Because there is more background, it can be nodular, it can be difficult. There's certainly a learning curve as part of it, but it's also hard because you really don't have as much morphology information on contrast mammogram. It's very uncommon that you can see the margins of an enhancing finding very well. And so it's difficult. And I would just, that is my caution a little bit about doing it for widespread screening. I think we certainly do need more experience. I know the BRAID trial is going to be presented at RSNA on Monday of RSNA. I'm looking forward to hearing their preliminary results. They did, I think, 2,000 women with dense breasts who had contrast mammograms, and they also had a group with MRI and another group with ultrasound. So it'll be very interesting to hear their results. And I know that the Netherlands are also doing a prospective study of contrast mammography now in extremely dense breasted women, like the original dense trial they did in MRI. So I think we do need some more validation for widespread screening. With the personal history patients, they are older in our patient population. I think the average age was closer to 60 as well. And there's less background enhancement, and the performance of contrast mammogram was really quite good. In the radiated breast, there's even less background enhancement, so it's even easier to see enhancing findings and suspicious findings. I think we do need to, at least collect evidence as we do it if we're going to start implementing contrast mammography for more widespread screening. It looks very promising, but I think we do have to have training and experience to not have too many false positives.
Doutora Wendie A, muito obrigada por essa manhã de discussões. A todos os outros, muito obrigadas. Nós estamos com o nosso horário em cima. Vamos dar sequência ao nosso evento e, mais uma vez, agradecer a todos pela oportunidade de estar aqui. Muito obrigada, gente.
Obrigada.
Obrigado.
Tchau.
Parabéns.